So thank you. Good morning, everyone. It's a pleasure to be here. And I'd like to also thank Dr. Larry Schulman and Dr. Lisa Kennedy Sheldon for the invitation. So I have three objectives this morning, and I'd like to provide with you, first of all, an overview of our Patient Care Connect program at the University of Alabama at Birmingham, our Comprehensive Cancer Center. Second, I'd like to actually talk more about cost savings in relationship to ER visits, hospitalizations, as well as ICU admissions. And then finally, to discuss patient satisfaction with care.
So this is all
Yes.
work, but you have to be really heavy-fingered about it. It's not working.
That's okay. You're not the first one to have this issue.
Well,
Cindy Trang explained it to me earlier. Can you advance?
there we go. Hopefully it'll work now.
All right, thank you. Okay, so the Deep South Cancer Navigation Network is also known as our Patient Care Connect program, was funded by an innovations grant from the CMMS, and the focus was really looking at the foundation as far as the triple aim of better health care, and lower costs. Oh, are you going to? Very good, thank you. As many of you probably know and heard yesterday, the earliest patient navigation programs were and continue to be nurses. Over the past decade, we've had an extension of the nurse navigator model to include trained lay navigators to provide services to patients, particularly in underserved communities. In the Patient Care Connect program, it is a lay navigation program that has been integrated into our care system. The focus are older adults with cancer. They were either on cancer treatment or in follow-up. This program was across 12 centers in the 5 southern states. It was a mix of academic health science centers, hospital-based, affiliated, and private practices. So we had a large mix across these states of our patient population. We had 12 nurse site managers, and 40 lay navigators. Next slide. Historically, earliest navigation programs did focus on prevention, screening, and early detection, and our experience at UAB with community health advisors with lay navigators goes back more than 25 years. But the PCCP built on our prior success, but focused instead on active treatment, survivorship, and end-of-life care. Our lay navigation model was also different in that we were focused on achieving health rather than emphasizing disease, promoting patient personal empowerment for patients and caregivers, as well as proactive participation, which is extremely important today. Now, our lay navigators were not licensed RNs or social workers, but they did have at least a bachelor's or a master's degree, and they were hired independently by each of the network sites. They were integrated into the health system. They were supported by their nurse supervisors, physician medical director, as well as administrative team. The essentials of the PCCP. The PCCP offered our services starting in March of 2013. This was considered standard treatment of care. Therefore, we did not have any random assignment to groups, which I'll discuss a little bit further later. Our enrollment was across a wide variety of venues, whether from a referral from providers and also self-referrals, as well as review of census reports on hospitalizations and ER visits. Our priority was given to high acute care patients, those who've had lung, ovarian, brain, hematologic, head and neck cancers, those with stage 4 cancers or metastatic disease, and also those with high-risk comorbidity, with diabetes, heart failure, COPD, et cetera. And given that this was largely a Medicare population, we had quite a few patients, clearly, who had comorbidity. The nurse site manager assigned patients to their navigators to initiate the contract. Next slide. Our lay navigators used the distress thermometer as the basic data collection of patient needs, and so I'm sure many of you, if not all of you, are familiar with the distress thermometer. However, given our geriatric patient population, we also had additional questions that were asked, such as comorbidity, informational needs, cognitive changes, spiritual and religious concerns, and quality of life were also added as questions and asked by our lay navigators. The navigators collected information using a very conversational tone. It encouraged discussion and trust with the patient and family member. Lay navigators did not assess, they did not manage, label, or diagnose. So here's an example of our care map that was used by the navigators, and all the care maps were developed by our coordinating care team at UAB under the leadership of Dr. Richard Taylor, who is a DNP. First of all, consistent with the distress thermometer, distress assessments with scores less than 4, we basically partnered with the patient and caregiver to provide that information and psychosocial support, opportunity for them to problem solve, as well as additional logistic assistance. If you had a distress assessment with scores greater than 4, the patients were referred to the nurse site manager who discussed the distress item and did the follow-up with patients. But also, in addition to patient empowerment, the navigators really helped patients to talk better and with their doctors, and also to be able to assess questions that they could be asked, so that the patients themselves who were navigated, could actually contact their provider as well. So there were various different routes in which the distress was attended to. So here is an example in terms of the different types of requests for assistance from navigators. As you can see, it's across physical, practical, emotional, cognitive, and informational needs. Excuse me. But you can see also that the biggest area in terms of concern had to do with information, how they were going to gather their information. So we used, for example, fatigue and pain informational pamphlets that were developed by the American Cancer Society for lay audiences, specifically with low literacy. We also help patients to ask questions and prompt them about their concerns, how to help them to talk with their doctors, and also to discuss with their site managers any other concerns. In addition, some of the other needs had to do with cards for transportation and giving brochures for insurance. Oh, you jumped. So, given that with our background, let's talk a little bit about the cost evaluation. We wondered whether our PCCP navigation could result in lower healthcare costs. Does it have a difference in terms of reduction in hospital stays, decrease in ED visits, decrease in ICU admissions? Second question, can the PCCP maintain patients on evidence-based clinical pathways? And third, will navigated patients have better satisfaction with care? In our methods, this was a secondary analysis of Medicare claims data from 2012 to 2015. We compared the costs of healthcare use for older cancer patients who received the PCCP, lay navigation, and matched them with a cohort of non-navigated patients. The sample, as I mentioned earlier, are all patients 65 years of age and older diagnosed with cancer, receiving Medicare Part A and B. And in addition to that, they had to also be included if they had at least 1/4 of observation before and 2/4 of observation after their enrollment into the PCC, because that was important in terms of evaluating the changes in the cost. Navigation was considered standard of care, as I mentioned, so that no informed consent was necessary for enrollment. And we also received a waiver of consent from the IRB to conduct the secondary analyses. Repeated measures, generalized linear models evaluated our trends in the total costs that were based on group assignment, quarters after enrollment, which is time, and calendar time. So the interaction between group and time was a primary coefficient of interest. Next slide. From that period of time, from 2012 to 2015, over 20,250 patients were included in our Medicare claims data. However, based on our valuation criteria and inclusion and exclusion criteria, as I mentioned earlier, there were a total of 15,912 patients. Now, what we first did was to match the navigated patients with those who were not navigated based on these parameters here. So in the non-navigated group, there were a little over 9,600 patients, and in the navigated group, we had 6,304 patients. So even before matching, that's my next slide, but even before matching, our navigated patients actually had higher acuity, they had a higher stage of disease, they had higher mortality or morbidity score, and they were also in receipt of chemotherapy. Next, we did a match of our navigated patients based also on these items in terms of age, gender, race, acuity, phase of care, comorbidity score, chemotherapy, et cetera. So we did a person-by-person match, and also you can see here that navigated patients were still more likely to have received chemotherapy. And these matching was based on propensity scores. So here are the results to show you in a graph here. We observed statistically significant group by time interaction for Medicare costs as well as healthcare costs. The cost for navigated patients groups began higher, as you can see on the left-hand side, but declined faster compared with matched comparison by $781 more per quarter per navigated patient. The cost became lower for navigated patients after 6 quarters. And if you look on the right-hand side in terms of hospitalization, inpatient and outpatient costs also show the largest between-group quarterly declines at $294 and $275 respectively. So the greatest mean quarterly cost declines were seen for inpatient costs, and the hospitalization overall declines by 7.9% per quarter. Here's the resource used regarding ED visits and ICU admissions. For the navigated group, our ED visits decreased by 6% or more per quarter, and ICU admissions declined by 10.6%. The total estimated decrease in costs was $19 million per year across the whole entire network. Oh, here's also the results of the regression analysis, which I just also discussed with you. Now let's talk a little bit about the Navigator workload. Each navigator had a mean of 152 patients per quarter. 72 of these patients were actively navigated. 83 of them had high acuity. And they also had a caseload of 30 newly enrolled patients per quarter. Patients were active 57 days. There was 3.3 face-to-face or phone contacts on average, and the average 1 contact every 18 days. Our salaries for our navigators range from $33,000 to almost $49,000. So looking at return on investment, the cost declined, as I mentioned earlier, a mean of $781, 29 cents more per navigated patient per quarter compared with our non-navigated patients. And that was an estimated cost of over $475,000 reduction in cost annually for a navigator managing 152 patients. So the navigator, just simply looking at the return on investment, the navigator with an annual salary of over $48,000, we had an estimated return on investment of 1 to 1.10. Let's answer the question about PCCP and the patient satisfaction. 90.7% requests for assistance were resolved to the patient satisfaction. This generally required 1.1 interventions that were resolved in about 11 days. And the decline in our request over time started with 18.6 in the Q3 of 2013 to about 9 in Q2 of 2015. So as you can see then here, what we're really seeing here is that the number of times that patients were asking for a request declined because they were actually able to increase their own self-management, the family self-management, increasing their own ability to navigate the system. Next slide. So what do we see? Well, first of all, we did see a reduction in resource use and cost for the PCCP. So this is cost reduction. It is not a cost effectiveness analysis. We saw clear benefit and patient satisfaction with the program, and also that our PCCP targeted high risk, high cost patients and those patients with unmet needs. The estimated potential of 1 to 1.0 ROI helps make this a financial case for the sustainability of navigation programs. And the navigators also were not limited by traditional model of clinic-based care. In other words, patients could contact them, they could contact patients either by phone, they could call them, they could visit them. They had many, many different times and ways in which they could see their patients. Where some of the limitations has to do with we did not have random assignment, potential confounding of factors such as social support, as well as the level of patient engagement may have influenced the level of navigation. The other piece about this here, I didn't get a chance to talk as much about the interaction across the different hospitals. There was a lot of communication, and there was an increase in engagement over time, so that our institutional sharing of data may have also supported this cultural shift in terms of looking at cost, maintaining also a resource decline. And also, the other limitation is currently today, we do not know what the long-term influence is clearly of the ACA as well as reimbursement practices, because without a transition to a values-based payment system, healthcare systems cannot necessarily implement or expand or even sustain their navigation programs. So in conclusion, our lay navigators and the PCCP supported patients with cancer from diagnosis through survivorship and end-of-life care. I did focus primarily on the hospitalization in this presentation. The PCCP healthcare costs and healthcare use actually showed a significant decline for our navigated patients compared with our matched groups, and that lay navigation programs can be expanded as systems transition to a value-based health system. And finally, I would like to share with you, I'm one of probably about 30 people that worked on the CMS project. It was really a terrific experience. Our lead PI on this was Dr. Ed Partridge, who was the Cancer Center Director for many years, and he has just recently retired. The program itself finished in 2016. We're still in the midst of a great deal of data analyses, and also this very, very strong, outstanding interdisciplinary group. We've had also postdocs and pre-docs also working on the program as well, and along with our Patient Care Connect group throughout the 5-state region. So thank you very much for your time.